Roger Hartl, who is a dear friend for many, many years. He's well known for his humanitarian work all over the world. He's a Henson McDonald Professor of Neurological Surgery, a lot of brilliant work on MIS, and looking forward to his talk on MIS regarding thoracic pathologies. Please unmute yourself, Roger. Roger, just good.
Can you hear me? Sorry.
Yes, we can. Brilliant.
All right. So apologies. So thank you, Salman. Thank you, Mehmet. And fantastic cases that Dr. Chen showed us, really challenging cases. I was asked to talk about MIS decompression for thoracic spine pathologies. And as most of you know, there are obviously many approaches to the thoracic spine. And many of these can be modified in ways, if you have the technology and the experience available, many of these can be modified to actually be used for less invasive approaches. So the transthoracic, retropleural, posterolateral, interlaminar, those are all approaches that are being used for open surgery. But again, if modified and if you have the experience and the technology available, many of these, you can actually replace them with less invasive approaches. And that's kind of what I'll try to talk about. Minimally invasive surgery, as you may know, I work a lot with the AO. We have a group within the AO where we try to define, and we came up with a curriculum for minimally invasive spine surgery for many of the procedures, primarily in the cervical and thoracic and lumbar spine. But the working definition of MIS is that you're trying to achieve the same or better outcome than traditional techniques by reducing local operative tissue damage and systemic surgical stress. And keep that in mind, that's the goal, obviously, with thoracic surgeries as well, whether you want to instrument or decompress, resect, whatever it is that you want to do in the thoracic spine. A lot of this can be done with less invasive approaches. But you got to be critical, and you got to always ask yourself, is this really safe? Can this be done safely in my hands? Do I have the training and the equipment available? We just published a book that summarizes a lot of the things that I'll talk about in my presentation here. So why do we need MIS approaches in the thoracic spine? Well, we saw previously, and you know from experience, obviously, access to thoracic pathology can be extremely invasive. Involves long incision, removal of resection of ribs, posterolateral resection of large portions of the bony anatomy. And obviously that comes at a price potentially in terms of infection risk, bleeding, recovery, and so forth. So the idea with less invasive surgery is to do the same job or a better job through a small incision, less soft tissue damage, less blood loss, and eventually get these patients back, hopefully, to their normal lives earlier than with traditional open surgery. I want to give you some examples of how we can utilize minimally invasive surgery in the thoracic spine to treat thoracic disc herniations. We saw some great cases from Dr. Chan that were done expertly with more open technology. Some of these, but not all of them, could probably be done with less invasive surgery as well. Ossified ligamentum flavum pathology, frequently an issue in the thoracic spine, can be treated with MIS sometimes. Some tumors, that's very tricky, but there have been reports, and I'm not going to talk about infection or fractures because that really goes into Corinne's talk later with instrumentation. Now, thoracic disc herniations, however, can be addressed frequently with less invasive surgery. And we just published this with Juan Uribe and some of the others. A group of experts around the world, we proposed a classification for thoracic disc herniations. And this is from that publication that is just coming out now. And it shows you different locations, different sizes of thoracic disc herniations. Type 0 is non-operative. Type 1 typically can be treated with a posterolateral approach. And then type 2 is more an anteriorly but relatively small located pathology, posterolateral or anterolateral approach. And then there are obviously calcified giant disc herniations in the thoracic spine, frequently calcified, and those are really challenging, as we could see in Dr. Chan's talk. And some of these can be treated with minimally invasive surgery, though. But they will typically then require a lateral or an anterior approach to carefully dissect this off the dura. So this is from that publication that kind of summarizes a classification of thoracic disc herniations, which I think is very helpful. This is a paper that was published just recently by Peter Bajkutz's group from Berlin, and they described the steps of a minimally invasive tubular retractor-assisted retropleural approach for thoracic disc herniations. We've utilized this for a number of years, but they did a really nice job kind of describing this step by step. And the steps, as you can you see here, involve partial resection of the rib, the retropleural dissection, which can be quite tricky sometimes, use of a tubular retractor, which I'll show you, and then finally removal of the disc herniation. So the patient is in a lateral position. You have to localize the pathology. I use navigation for that. You can do that with fluoroscopy, of course. You have to resect a small portion of the rib usually to get access with your tubular retractor. You need quite long tubular retractors. We use the retractors that typically we use for the lateral approach, for the translumbar lateral approach, which are expandable retractors, but you can also use a fixed tubular retractor. And then you gain access to the lateral portion of the spinal anatomy there, the rib head, and the lateral portion of the spine. Localization obviously is very important, and you have to do that with fluoroscopy or navigation. And here they show very nicely how they have resected then part of the rib head, the pedicle, to get rid of this calcified thoracic disc herniations very effectively. Now, if we do this in the mid-thoracic spine, even if we remove a pedicle on one side, I usually don't instrument. If I do it in the lower thoracic spine at T10, T11, T12, I will usually put a plate on top, and I'll show you an example. We also published about 10 years ago, we published a series of thoracic disc herniations, calcified and not calcified, that were treated with a minimally invasive lateral approach. We published that 60 patients back then, very successfully treated as an example here. And the key again is to come in from the side, remove the rib head, remove the pedicle, and then you create under the microscope, you create a cavity anterior to that disc herniation, and you pull very carefully, dissect the disc herniation away from the dura and push it into that cavity. That's the safest way of really resecting that calcified disc herniation. This is a case that I did a number of years ago. This was a T11, T12 thoracic disc herniation. And this was I thought it would probably be intradural. As you can see here, the calcification, this pinpoint that's pushing kind of into the dura. I elected to treat this with it was T10, T11, actually, not T11, T12. Elected to treat this also through a tubular approach. And I think we went in from the left side. This patient had a myelopathy. So the patient is positioned in the left side with the left side up. I tape the patient down. I use navigation for this. I used to use fluoroscopy, but navigation is nice because once you get your spin, your intraoperative CT scan, you don't need fluoroscopy anymore. And you can navigate at any point of the procedure without having to put on lead or call the X-ray tech. It really gives you a lot of freedom during the surgery then, as long as the navigation is accurate, obviously. So the left side up over T10, T11, we make a small incision. We resect a small portion of the rib. And if you do a fusion, you can use that for the fusion later on. Then you use your dilator. That's from our presentation, from our paper about 10 years ago. We use a series of dilators. You go down, localize over the lateral aspect of the spine, confirm all that with navigation, of course. And this is the reference array for navigation and the iliac crest. And these are some of the screenshots from navigation. So you can see we're pointing here to the pedicle here, the rib head. Those are kind of like the landmarks that you're using when you try to orient yourself in the spine and in the spinal canal. And then you remove the rib head, and underneath the rib head, you look for the pedicle. This is the pedicle, and you can see in the middle is that thoracic calcified disc herniation that's pushing into the spinal cord. So we're going on with a navigation probe over the pedicle. We find the caudal portion of the pedicle, the cranial portion of the pedicle, and then eventually we drill down the pedicle, resect it, and create a window so we can actually get in there and see part of the dura, and then anteriorly you see the calcified disc herniation pushing back into the dura. So this is a T10, T11 from the left side. And I think that this picture, this video kind of shows it nicely. So we have cranial on the right, caudal on the left. And I'm kind of mobilizing that calcified disc crenation here with the ball tip now. I dissect the disc away from the dura, and you can see it has like this cheese type of configuration. It's not a totally calcified disc crenation, thank God. And you can kind of dissect it off the dura here very nicely. And you do this very carefully, you can get a CSF leak. There are instruments available that you can use through a tubular retractor to fix CSF leaks if those occur. And then in this case, because it was in the lower thoracic, I elected to put a lateral plate to stabilize, and I put a cage into the disc space as well. And that's the post-operative X-ray and the post-operative MRI scan. Another case I want to show you, this is a patient who had a T11, T12 thoracic disc crenation and presented with a foot drop. It's a very unusual presentation, but there's a whole literature. There's literature about about patients presenting with lower motor neuron lesions, typically a foot drop from a T11, T12 disc crenation. So this patient did not have a myelopathy, but we wanted to decompress this, and we did this with an MIS TLIF approach, the same approach that we would typically do in the lumbar spine for one-level lumbar fusion. So we did 2 small skin incisions with navigation. We placed the screws, placed the tubular retractor, did an over-the-top decompression of the pathology, and then placed an expandable cage here. This cage goes in at 6 millimeters, and it's really nice for the thoracic spine because the disc space there is obviously very collapsed usually, and then you can expand it as needed. So essentially a TLIF approach in the thoracic spine to decompress a thoracic disc crenation. A few more words about decompression in the thoracic spine, and this is now for ossified ligamentum flavum. There's a fair amount of literature, especially from Asia. So the ULBD, so the unilateral laminotomy for bilateral decompression through a tubular retractor, can be utilized very, very safely, very, very effectively in the thoracic spine. Obviously, you got to be very careful under the microscope. I do this with calcifications and adherence. It is possible to close the dura through a small tubular retractor, though, but you got to train that. And this is from a publication where they described the monosegmental resection here of a calcified ligamentum flavum. They did a very nice job in this publication. And the advantage is that incisions are small, infection risk is minimal, there's no bleeding, but it requires really training. And then one step up with the endoscope. This can be done with the endoscope as well. I don't do endoscopic surgery, but this is something obviously that many of you are familiar with endoscopic surgery, and this is obviously a challenging undertaking in the thoracic spine. You got to be really careful, especially when it's calcified, but it has been described and it can be done safely. Now, this is something that I personally wouldn't do. I would not resect a thoracic spine meningioma or any kind of lesion of this size through a tubular retractor, but it has been described. I think minimally invasive is great, but I think patient safety is more important than any type of minimally invasive surgery. So I would certainly do this with open surgery, but it has been described with MIS, and in this case they did it successfully. But I think here the risks, in my opinion, clearly outweigh the benefits. So to summarize, MIS approaches have been described for pretty much all thoracic pathologies, and many of these seem to be feasible, safe, and effective. There are advantages, obviously, to open surgery. I think that for certain pathologies, the advantages outweigh the risks. And but it is also clear, in my opinion, that now with advances in navigation, augmented reality, less invasive implants, instrumentation, there's lots to come. So this is a really exciting topic. So thanks again for having me, and I hope Corinna has enough time to give her presentation. Thank you.
Thank you, Roger. I think another brilliant talk, amazing cases, and to do all that through MIS was wonderful. And looking forward to hearing from you in the end when we discuss this.